Hi, I'm Jeff Travers from Wright State University, and my abstract 628 is entitled Evidence that Wounding of Geriatric Skin, which upregulates IGF-1 levels, protects against both abnormal carcinogenic UVB responses as well as from the development of non-melanoma skin cancer. So I have no relevant conflicts of interest. When considering the primary risk factors for non-melanoma skin cancer, it is well known that the UVB component of sunlight as well as advancing aging are these. What I'm going to be talking about is basically a new paradigm for the role of aging in non-melanoma skin cancer, which involves fibroblast senescence, IGF-1, and non-melanoma skin cancer. These studies were actually started and continue to collaborate with my colleague Dan Spondau at Indiana University. So if you think about the role of IGF-1 in keratinocytes, first of all, our group has shown that it increases DNA repair enzymes. IGF-1 also temporarily halts DNA synthesis following genotoxic stressors such as UVB, which then allows a cell time to repair any DNA damage before proliferating. And then finally, if a keratinocyte can't repair its DNA damage following UVB, the cell will become senescent, so it will no longer continue to proliferate with possible mutations. Now, relevant to aging, keratinocytes have the IGF-1 receptor, but they do not produce IGF-1. In the skin, most of the IGF-1 supplied to the epidermis is produced by dermal fibroblasts. If you're young, your fibroblasts make a lot. As you age, your fibroblasts become senescent and they make less IGF. And we believe that this is one major explanation for why non-melanoma skin cancer is seen in older individuals. And these studies are more relevant, we believe, for actinic keratoses and squamous cell carcinomas than basal cell carcinoma. So I'm going to first review the premise of previously published data, which sets up the current findings. About 10 years ago, our group did some studies where we looked at young adults and geriatric adults, and skin with one minimal erythema dose, and then waited 24 hours, did biopsies of the areas. We asked the question, what percentage of cells were Ki67 positive and thymidine dimer positive. And so Ki67, as you know, is a proliferating marker, and thymidine dimer will measure DNA damage. And an appropriate response 24 hours after UV would be cells that are Ki67 positive, that is, they're proliferating, or thymidine dimer positive, both. Whereas we believe an inappropriate response would be cells that are both Ki67 and thymidine dimer positive. That is, they're proliferating while still having DNA damage. This is an example of a patient who 24 hours after UV biopsies were performed, and as you can see on the left panel, you have a Ki67 positive basal epidermal cell, and then the center panel is thymidine dimer positive cells, and if you merge the two, you see the cell is Ki67 but not dimer positive. Now, in contrast, this is as an example of an inappropriate response where a cell is both Ki67 and thymidine dimer positive. So in geriatric subjects, all of the subjects had cells that were Ki67 thymidine dimer positive. However, young adults, we did not see that. And we wanted to confirm that IGF-1 mediated this effect by giving back IGF-1. So in these studies, what we did was we took geriatric subjects, injected their skin with saline or IGF-1 30 minutes, and UVB irradiated the areas. Waited 24 hours, did biopsies, and then measured Ki67 thymidine dimer positive cells. As you recall, in young adults, they have very few of them, geriatrics. If you take geriatric skin injected with saline, it appears just like normal geriatric skin. However, geriatric skin treated with IGF-1 now behaves or responds to UVB similar to young skin. So this sets up our idea of using wounding therapy such as dermabrasion or fractionated resurfacing to remodel geriatric skin, thus bringing in new fibroblasts and increasing the IGF-1. We have previously published data where we did dermabrasion or fractionated resurfacing and queried the skin at 3 months. And as you can see, the amounts of collagen 1A were elevated in all of the wounding. The numbers of senescent fibroblasts were also decreased. They were increased in normal geriatric skin. However, 3 months after either dermabrasion or fractionated resurfacing, the numbers of senescent fibroblasts as measured by 53BP1 were significantly diminished. Not surprisingly, and consistent with our hypothesis, dermabrasion or fractionated resurfacing at 3 months resulted in increased levels of IGF-1 as measured by messenger RNA to levels seen in young adult skin. And then our UVB response, as you can see by part B, fractionated resurfacing or dermabrasion resulted in normalization of the abnormal geriatric UVB response. So the next aspect is to do long-term studies to define how long these protective effects of wounding last. So with that in mind, we enrolled geriatric subjects and then did fractionated resurfacing of a localized area of skin and had them come back 1 or 2 years post fractionated resurfacing. And as you can see by the bottom part C, fractionated resurfacing at 1 and 2 years resulted in at least 2-fold increase in the levels of IGF-1 messenger RNA. And then as A and B for 1 and 2 years post-fractionated resurfacing, the numbers of Ki-67 thymidine dimer double positive cells diminished significantly. So this indicated that this response of fractionated resurfacing appeared to be durable. So next, we enrolled geriatric subjects at our Dayton VA dermatology clinics who had at least 5 actinic keratoses on each forearm. These were non-diabetics, and what we did was we did fractionated resurfacing to left or right arm depending upon odd or even social security number, and then monitored the subjects over time. Not surprisingly, fractionated resurfacing diminished the number of actinic keratoses on the treated arm. And as you can see, this response is quite durable even at 18 months in this population. And as you can see in this part, the fractionated resurfacing resulted in a negative slope. Finally, the part that is really fascinating is that in these subjects, which are basically high-risk subjects, we have noted 16 skin cancers on 13 subjects, 15 of the control, and only 1 skin cancer on fractionated resurfaced skin, with the majority of these skin cancers being squamous cell carcinomas. So in conclusion, wounding of geriatric skin results in increased IGF-1 levels and normalization of the acute UVB response. And our laser responses appear to be durable up into 2 years. We're continuing this ongoing study to test fractionated resurfacing to not only inhibit actinic keratoses, looking at future formation, but also to prevent non-melanoma skin cancer. This confirms this new paradigm involving IGF-1 and fibroblast senescence. And this type of technology could be of consideration for our high-risk patients. I want to thank our research group, of course, long-term collaborator Dan Spondau, and Dr. Kemp, who's here at Wright State, our pharmacology translational unit, and definitely our patients. If you have questions, email me at jeffrey.travers@wright.edu. And be safe out there.